Thank you very much, Dr. Koren. Are there questions from the audience?
Gideon, in the same context that we need to provide advice to policymakers in the U.S., how can that dialogue, how does that dialogue take place in Canada, and what are the strategies that we can use jointly to enhance the way that the regulatory agencies and policymakers think about therapeutics in pregnancy and in children?
Yeah, unfortunately, because we answer also a lot of American callers, some of our lines cover the whole continent, I'm painfully aware that both FDA and Health Canada do not have yet a mechanism to do it. I do know that FDA, for example, convened an advisory group about the SSRIs, but again, I am very disappointed in what they put together. They never discussed the risk-benefit ratio appropriately and so on. The way to do it is simple. It's common sense. Health Canada and the FDA cannot be expected to be experts in everything. Both countries, and maybe together, should have a group. The fact that the SSRI statements this year were released without the Psychiatric Association involved, without the obstetricians involved, without Motherisk and similar associations, mean that the agencies did not seek external advice from people who practice this day on, day out. We deal with this every day. I think about this 24 hours a day. Why wouldn't they ask me about it? And not that I want to go to Ottawa or not, that's not the point. For example, the whole perception of risk. Before you release something like this to a public, all of us in medicine know what knowledge transfer, knowledge translation, what happens when you release something. The effects are far beyond what you thought it will be. But there is experience there. Why it's not being incorporated into decision? So actually, we are begging the regulatory agency in Canada, less in the United States, to use free resources that are available. It's an example that the silo of government does not talk to the silo of academia, and that's not justified. I don't think the Canadian public wants to know that people don't talk to each other before they throw such statements. I have more examples, I didn't want to go. Health Canada last year said that the Accutane problem is an American problem. We don't have it because the surveillance system did not show it. It's published in CMAJ of last year. But in the same letter, they said that they were at the FDA proceedings, and guess what? In the FDA proceeding, there were 15 cases from Canada, and they claim they didn't know about them. So I think pregnancy is not taken seriously. Pregnant women now moved to CEOs, to everywhere, presidents of universities. But when it comes to pregnancy, I have often the feeling, Don, that women are slaves. It's like they were 2,000 years ago. And I don't understand that mentality. I don't understand. And again, I may be cynical in saying that if that happened in another area of consumers, such as the auto industry, it would not work. I don't know what's there in pregnancy that causes women to be so orphaned. But if we don't do the difference, it will not happen.
Dr. Koren, my name is Martha Painter, and I was a member of the scientific advisory panel that unfortunately chose not to do anything about the pregnancy prevention program. At the time that I was asked to join the panel, I was a 23-year-old grad student. I was given 2 days to read, I'd say, 2,000 pages of material, and then put with a room full of, mostly, no offense to yourself, but older men. When the report came out, I was stupefied that 8 hours of very heated discussion had come down to about 5 sentences, maybe 7 sentences. And I wrote a minority report to complain about how I felt I'd been treated during the meeting, what was expected of me in this meeting. I have no idea why I was asked to do this and not you. That report I asked to be publicly put on the website with the scientific advisory report's proceedings. It was not. I contacted Health Canada an absurd amount of time. Nothing was done. David Roy out of the Bioethics Centre in Montreal tried to help me with this. They didn't even listen to him. I also sent it to numerous media outlets. Nobody responded. Globe and Mail, Canadian Press, et cetera, et cetera. I deeply apologize. That's all I can say.
Yeah, I don't want to be cynical. For the sake of transparency, I should tell you, I was invited to talk to the Advisory Committee of Health Canada about the Accutane, but it so happened I was out of the country at the day they planned to do it. So I want to be fair. I'm not so sure personally that the I-Pledge solution that the Americans took will work better or not, and access to the drug and so on. But clearly, so I did not try to say that Health Canada hesitation to go the American way on that particular one is wrong or right. I personally very strongly believe that the way to change is through physicians who prescribe it and not through other ways. And most physicians don't do what they're supposed to do. So it's as simple, it's not rocket science. It's to follow guidelines which are not difficult to follow. And those of you who practice or do research is not surprised. Compliance by physicians is a very, very problematic area with guidelines, with changes. And so there are other solutions. But so I don't want to relate to that report itself. I do have the impression that with the Accutane there was, and continue, it's not now Accutane, it's isotretinoin, there are other forms. There is a candid discussion going on with Health Canada. I just think that we have to create a new model that Health Canada and hopefully FDA come to people who practice that field on a regular basis, not only when there is a crisis. There are scores of new drugs every year on the market, and it's only a matter of time that women will take them, only willingly or not knowing. 50% of pregnancies are unplanned. So unless there is an ongoing effort to address those, it will always be reactive. This should be proactive, not reactive.
Gideon, it's Gail Robinson. I think that we as physicians have to take a little bit of responsibility too, though. In talking to the other psychiatrists in Toronto who are dealing with women's mental health, one of our problems where we're bad is we don't do enough reporting. I've had thousands of women on antidepressants during pregnancy. I have, thank God, not had one case of any problem with any baby, but I also haven't reported that to you. So what happens with reporting systems is that there's this negative bias. If there's any kind of problem, people are likely to report whether or not it's related to the drug. And we're not reporting all the women we have who don't have any problems when they are on antidepressants or other psychotropic drugs during pregnancy. So, maybe we should be getting together and trying to develop a simple reporting system so that you have more ammunition to show that we're using this properly and it's not causing problems.
Yeah, I again don't want to be cynical, but to expect the medical community to report didn't work anywhere in the world. Britain has some interesting experiments going on. This approach, some people it takes so many years for one report come from a physician. So the spontaneous reports will always have that issue, and we are aware of that, of course. That's what Motherisk, we talk to women during pregnancy, following them up prospectively. So that's, in a way, a reporting system. And guess what? Health Canada wanted to capture that information into a new system called MotherNet, only to stop it after 2 years, blaming lack of funding. And the system does not agree. It does not exist. If it was there, by now they would know how many Accutanes are there and the outcome of everyone, not just those. So here, there are more and more examples that there's no political will to work for pregnant women. And that's what I personally, as a citizen, not as a scientist, want to change. The spontaneous reporting will not work. It just doesn't work. Clinicians, 20% of Canadian or Ontarians have no family physician. So physicians are working hard and will not have the time to report. I'm not saying it as a justification. That's the case. And even if you double the reporting rate, it's still only 2%. So again, the bias will prevail. So there are issues here. You need other systems. Administrative database, friends from Manitoba, our colleagues in Quebec now starting to do the administrative databases. That can be done in provinces where prescriptions are done by the province and outcome is known. That's Northern Europe is using now for 15, 20 years successfully. And some of our colleagues in Ontario cannot do it because we do not have such plan, but Manitoba has, Quebec has, Saskatchewan has. But also the prospective one done by Motherisk, which tell you what women take now, because you have to realize with a database you can begin to do it only after several years that people took a medication that you begin to have outcome. Whereas we see the first woman who take that medication in pregnancy for multiple sclerosis or for anything else. So we need concerted effort by everyone, not but one or two people or approaches. But we need to bring the political level interested in pregnant women. Otherwise, we will not be able to break through in this area.
I think to be fair, this actually is important for pregnant women, but it's not actually unique. Drug safety is a funny area because if you look at the broader context, I think Bruce Carlton from UBC has the most articulate illustration. If you look at the people in North America, there's the equivalent of a fully loaded 747 crashing into the ground every day. People who die from adverse drug events. And that's just die. Yet that clearly would be unacceptable for the aviation industry. Yet in drugs, we seem to accept it as just a way of doing things. So I think drug safety in general, pregnant women are a special case because there's a lot of sensitivities around it. But nonetheless, drug safety in general is an area in which we as a society, for reasons which are not immediately clear to me, accept a different standard of safety than we would from other areas.
I'm glad you brought it up because, of course, what I tried to show you, we're talking about the risk to the fetus, which is natural and we should. But the risk of the untreated condition is very sparsely described. Merck reported to us of a case of a woman who was on Montelukast, because it was the only drug that settled her asthma, who got pregnant and decided that she doesn't want to endanger her fetus, and she died of an acute asthmatic attack after stopping her Montelukast. A woman with depression that stops her medication and tries to commit suicide. Where do you calculate those risks? And how can we be so cavalier, not remembering that risk? Isn't medicine is about risk-benefit and not just risk? And that's right. There is something cavalier about how we take adverse drug events.
One last question, please.
In drug development in phase 1 to phase 3, we exclude women, pregnant women, and also children, especially. And then we go to the phase 4, and in real world, we are in face with these kind of scenarios. As an expert, what is your solution that legally and also regulatory we can include pregnant women in phase 3, that we don't have the biases for risk assessment, benefit or risk?
You have to be more clever, of course. So first of all, if it's a condition of first trimester, such as NVP, well, there are companies now doing studies on women when they need the drug. Beyond the first trimester, there's no risk of dysmorphology. So unless you have very compelling evidence of brain development issues, there's no reason not to study those drugs. The problem is that drug companies, for legal reasons, which I understand, will not put... It's for them easier to tell you, don't use my drug, and you cannot force any private enterprise to label something to what they don't want. That's where governments, FDA, but mostly NIH, CHR, should step in. That's where academia should step in. And these studies are needed. And For each case, you will have to do down-to-earth risk-benefit assessment to ensure. And you can learn a lot from women who took the drug anyway. Many psychiatrists you heard today and other continue to treat pregnant women because they're afraid for the well-being of the woman. You can capture that energy, not into RCT maybe, but I believe that the next generation is not the generation of the RCT. RCTs are, we all know everything we want to know about them. This is now the era of the observational studies, how you collect information that relate, as Don said, to everyone, not just to a small selected group, and how you handle the variables that you need to know. So we have already very encouraging results showing that when you could, for example, with beta blockers, there are randomized trials for hypertension in late pregnancy. Results are very similar to the observational studies. So I think there are many solutions. I didn't have time to go through it, but the proceedings of this meeting that will be published in the Canadian Journal of Clinical Pharm will have a paper answering some more depth what you were asking. Thank you.
I'd like to thank